Chapter 18, Preoperative Care. For a med-surg course, we've had a lot of meds so far, but not a lot of surge. We know what surgery is. It's that art and science of treating diseases, injuries, and deformities by operation and instrumentation. Performed for a lot of reasons: diagnosis, cure, palliative, prevention, cosmetic, or even exploration. There are a wide variety of surgical settings that could be chosen. Everything from elective surgery to emergent surgery, inpatient surgery with a same-day admission to ambulatory outpatient settings. In our first case study, JD, a 45-year-old female, presents to the surgeon's office for a pre-surgical workup for a right breast lumpectomy. What would your role be in the pre-op assessment of this patient? Have knowledge of the nature of the disorder and requiring surgery? Identify the individual patient's responses to the stress of the surgery? Have knowledge of the results of preoperative diagnostic tests? And identify any potential risks and complications that the patient could be at risk for with this surgery. During the initial patient interview, we will obtain health information, including drug and food allergies, provide and clarify information about the surgery and the anesthesia, assess their emotional state and readiness, and determine any expectations the patient may have. We're going to review the patient's chart thoroughly well before any scheduled surgeries. This is to ensure that all informed consents and other crucial assessments have been completed. JD is accompanied by her husband. She tells you she has 2 school-aged children. She states that she is here because she has her breast biopsy was positive for cancer, and she anticipates that the lumpectomy will remove all cancer. Our overall goals are to identify any risk factors the patient may be in danger of, and to plan the care to ensure patient safety. We want to establish baseline data for comparison, both intraoperative and postoperative. We want to determine the patient's psychologic status to reinforce coping skills, and determine any physiologic factors the procedure may contribute to the risks this patient faces in recovery. JD states that her mother and aunt have a history of breast cancer resulting in mastectomy. She appears anxious, and you note constant fidgeting. There's a wide range of assessment goals we're going to need during this procedure. Everything from identify and document the surgical site, identify drugs, over-the-counter medications, and herbs taken that may affect the surgical outcome, review results of preoperative diagnostic studies, identify cultural and ethnic factors that may affect the surgical experience, determine the receipt of adequate information from the surgeon to sign the informed consent, and determine that consent form is signed. During the psychosocial assessment, we want to monitor for excessive stress response that can be magnified and affect recovery. There's many influencing factors to this, everything from age, past experiences, current health, and the socioeconomic status. During the assessment, we want to use common language, use translators if needed, for NCLEX or ATI if there is any hint of a language barrier. If the answer involves getting an interpreter, that's going to be the answer. That's going to be a very high priority that you see come up a lot. We also want to communicate all concerns to the surgical team. That anxiety can impair cognition, decision-making, and coping ability. We want to make sure we're providing all information in a very clear way to help alleviate that patient's anxiety, help overcome that lack of knowledge, make sure they have realistic expectations. And the more information we can provide about the procedure, the more at ease the patient's going to be. Anxiety may arise from the conflict with interventions, such as blood transfusions in the case of Jehovah's Witnesses, and religious or cultural beliefs. Surgery is going to be a nerve-wracking experience for everyone. Everything from that fear of death or disability may prompt them to postpone. We also want to make sure they're very aware of the pain treatment following surgery. We want to confirm that the drugs will be available, and we want to make sure we've done everything we can to alleviate these patients' concerns. Depending on the surgery, recovery could take a significant amount of time and could result in a serious disruption to their life and functioning. These concerns could range from fear of permanent disability to temporary loss. They could also include family and financial concerns. Hope may be the strongest positive coping mechanism, and we want to make sure we can assess and support this patient every way we can. We also want to make sure we obtain a thorough past medical history, including diagnosed medical conditions, previous surgeries and problems, menstrual and OB history, as well as familial diseases, inherited traits, conditions, and reactions slash problems to anesthesia that any family may have had. On assessment, JD tells you she has a history of hypertension and that she was recently diagnosed with diabetes, for which she currently controls with diet and medication. We want to make sure we have a thorough and accurate med reconciliation, including prescriptions and over-the-counter drugs, herbs, dietary supplements, a special focus on antiplatelets and NSAIDs, as well as any recreational drugs such as alcohol, tobacco, or any other illicit substance. Due to the anesthesia, drug intolerances and allergies will be another priority assessment prior to any surgeries. We also want to focus on idiosyncratic reactions and screen especially for latex allergies, any risk factors, contact urticaria or dermatitis, aerosol reactions, or a history of reactions suggesting a latex allergy. In addition to taking hydrochlorothiazide and glipizide, JD is currently taking a multivitamin, fish oil, and a daily low-dose aspirin. She reports an allergy to penicillin resulting in a rash, and she reports no previous surgeries. During the review of body systems, we want to both confirm the presence of disease as well as confirm the absence of disease to make sure we're absolutely positive there are no underlying conditions we're unaware of. We also want to set alerts to areas to closely examine and provide essential data to determine specific preoperative tests. For the cardiovascular system, we want to make sure the patient reports any cardiac problems that should be closely monitored during the surgery. These would include things like hypertension, angina, dysrhythmias, heart failure, or MI. We should also include the use of any cardiac drugs as well as the presence of any pacemaker or implanted cardioverter defibrillator. Telemetry should be monitored closely throughout the surgery, as well as a 12-lead EKG, coagulation studies, possible prophylactic antibiotics that may be needed, or venous thromboembolism prophylaxis. For the respiratory system, we should inquire about any recent or chronic respiratory diseases, including infections, procedures that should be canceled because of increased risk of laryngobronchospasm, history of smoking, or a decreased SaO2. We should listen to the patient's lung sounds and assess the respiratory system carefully, and also assess for a history of dyspnea, coughing, or hematitis, COPD, asthma, or any other condition that would place them at high risk for atelectasis or hypoxemia. Smokers should be encouraged to stop smoking at least 6 weeks before the surgery. This not only decreases the risk of complications, but also should be assessing for sleep apnea, obesity, and airway deformities that could affect respiratory function as well. For the nervous system, we should carefully monitor the neurologic functioning, including vision or hearing loss that could influence the results. Monitor for any cognitive deficits that could affect the informed consent and cause adverse outcomes during and after surgery. This could be especially crucial to assess in older adults, and added stressors may contribute to the emergent delirium. For the genitourinary system, we need to monitor for a history of renal or urinary tract diseases. Renal dysfunction is associated with fluid and electrolyte imbalances, increased risk of infection, impaired wound healing, and altered response to drugs and their elimination, which could be crucial with the anesthesia. For the genitourinary system, we need to perform renal function tests, note any problems voiding and inform perioperative team, assess men for prostate problems, and assess women for the possibility of pregnancy. And we also need to be assessing the liver closely as well, as that could also play a key role in detoxifying any anesthetics. A thorough head-to-toe assessment should be performed with a history of skin and musculoskeletal problems. Any history of pressure injuries, we should provide extra padding during the procedure, as they will be on a cold table and unable to protect themselves from injury. And we also need to be aware of any body art, such as tattoos, piercings, or anything else that could put them at a higher risk for skin breakdown. We also want to identify any joints affected with arthritis or any mobility restrictions that may affect their positioning and ambulation while on the table. For the musculoskeletal system, we want to report problems affecting the neck and or lumbar spine. Spinal anesthesia may be difficult with certain patients with certain surgical histories, And these spinal problems could also affect airway management and anesthesia delivery. And the endocrine system should be thoroughly assessed as well, including patients with diabetes who are at risk for hypo or hyperglycemia, ketosis, cardiovascular alterations, delayed wound healing, or infection. Considering her diabetic history, what assessment is important for JD the morning of her surgery? Patients with diabetes, we want to assess their blood sugar carefully before the procedure. We're going to do this with the normal capillary glucose test the morning of the surgery. And we're also going to clarify with the surgeon as exactly what insulin dose he would like to give, as opposed to relying on the usual sliding scale. Hyper and hypothyroidism also pose surgical risks due to the altered metabolic rate. Make sure to verify with the surgeon again before giving the scheduled thyroid medication. For patients with Addison's disease, abruptly stopping their replacement corticosteroids could cause an Addisonian crisis. Stress of surgery may require an increased dose of the IV corticosteroids. Patients with a history of compromised immune system or the use of immunosuppressive medications can have delayed wound healing or an increased risk of infection. These immunosuppressive drugs may need to be tapered before the surgery. Fluid and electrolyte status must also be carefully assessed. Everything from vomiting, diarrhea, or preoperative bowel preps can cause imbalances. We need to make sure we're identifying drugs that can cause changes to this balance, such as diuretics, and carefully evaluate those serum electrolyte levels. We also want to make sure that the MPO status is closely followed, as a surgery delay may also lead to dehydration. Patients with or at risk for dehydration may require additional fluids and electrolytes before surgery. Nutritional status and nutritional deficits include overnutrition as well as undernutrition. Provide extra padding to underweight patients to prevent pressure ulcers. May be protein and vitamin deficient, and identify their dietary habits that may affect their recovery, such as caffeine. For obese patients, stresses on the cardiac and pulmonary system should be closely monitored. We should also be aware of the increased risk of wound dehiscence, meaning an abnormal opening of the surgical wound. Also, infection and insertional hernias. Slower recovery from anesthesia and slower wound healing all around. For our pre-surgical exam, we want to complete a thorough physical examination. Document any relevant findings and share with the perioperative team. We also want to obtain and evaluate the results of all labs and monitor the glucose carefully. The Joint Commission requires a history and physical, and these findings enable the provider to rate patients for anesthesia administration, and this is a major indicator of perioperative risk and overall outcomes. During the preoperative teaching, the patient has a right to know what to expect and how to participate. This not only increases patient satisfaction, but also reduces their fear, anxiety, stress, and pain. While time may be limited, make sure that we're addressing the patient's needs at their highest priority, and include information focused on safety. We also want to provide written material to reinforce our teachings later for the patient to refer back to. Several days before the surgery, we want to make sure we observe and listen to determine the amount of teaching for each session. Anxiety and fear can hinder the patient's learning, and make sure to give priority to the patient's concerns. What teaching should be given to JD before the day of the surgery? And what does she need to know on the day of the surgery? We need to make sure we're explaining everything about the surgical procedure, including marking the surgical site, the type of anesthesia, the expected recovery time, any medication management for the day of the surgery, what to take, what not to take. And on the day of the surgery, make sure we're reinforcing the preoperative teaching, answering questions, and clarifying any information that she still may be unsure of. We need to make sure that an IV has been started preoperatively. Her blood sugar will be monitored both pre-op and post-op, and sedatives and pain medication that may be administered. For the preoperative teaching, there are 3 types of information: sensory, process, and procedural. This teaching must be documented and reported to the postoperative nurse. We want to be careful to avoid the duplication of information and also assess the patient's learning throughout the process. During the preoperative teaching, teach deep breathing, coughing, and early ambulation as appropriate. Also inform the patient that if tubes, drains, and monitoring devices or other special equipment will be used postoperatively, and to provide any surgery-specific information the patient may need for recovery. Don't neglect the basic information prior to arrival, including the time and place, what to wear and bring a responsible adult if needed, and any fluid and food restrictions. During legal preparation, check that all required forms are signed and in the chart. This includes informed consent, blood transfusions, advance directives, and any power of attorneys. Keep in mind that any informed consent must include an adequate disclosure, a clear understanding, and that it was voluntarily given. The surgeon is ultimately responsible for obtaining the consent. The nurse may witness the signature, verify the patient has understanding, and permission may be withdrawn at any time. A legally appointed representative of the family may consent if the patient is either a minor, unconscious, or mentally incompetent. An emancipated minor is younger than legal age but is still able to provide their own legal consents. A medical emergency may override the need for a consent. This includes immediate medical treatment needed to preserve life or prevent serious impairment to life or limb. JD signs her consent in the presence of the surgeon in his office before the day of the surgery. This was an informed consent, though it is your role as a nurse to verify that the consent is signed, witnessed, and on the chart. During the day of surgery, complete all final preoperative teaching, assessment and communication of any pertinent findings, and verify again that informed consent is signed. We also want to do any day of surgery laboratory and diagnostic results, history and physical examination, consultations, baseline vitals, a proper skin preparation, any nurse's notes, and make sure again that the surgical site is clearly identified. JD reports to the outpatient ambulatory surgical center on the day of her surgery. How will you help her to get her ready for the OR? Additional day of surgery preparation would include a hospital gown. The patient should not wear any cosmetics. Make sure to observe the skin color is important and remove any nail polish for the pulse oximetry. Others would include valuables are returned to the family members or locked in a safe. Also make sure there's careful accounting of any dentures, contacts, glasses, prosthesis, and the patient is clearly identified along with any pertinent allergy bans. We also want to make sure that the patient voids before surgery, before any preoperative drugs, to prevent any involuntary elimination under anesthesia. This would also reduce the risk of urinary retention during the early postoperative recovery. There could be a wide range of preoperative medications given, including benzodiazepines, anticholinergics, opioids, antiemetics, or antibiotics. The patient could also receive their scheduled dose of beta blockers, insulin, or even eye drops. The patient will be transported to the OR via stretcher or wheelchair and include handoff communication, including that S-bar assessment, including situation, background, assessment, and recommendation, and the caregiver's direction to the waiting room to wait for the procedure. You administer IV midazolam as ordered to JD and prepare to hand her off to the OR nurse. A pertinent S-bar may include for S that JD is a 45-year-old female with history of breast biopsy positive for breast cancer. She is here today for a right breast lumpectomy to be performed by Dr. Evans. Under background, she has a family history of breast cancer and appeared anxious this morning, verbalizing this history and her own fears. She is married with 2 daughters. Her husband is here in the waiting room. She also has a history of hypertension, type 2 diabetes, controlled with glipizide, and diet. Under assessment, her baseline vitals were 36.8, 78, 122, with a blood pressure of 132/70. Her fasting blood glucose this morning was 82. She took her hydrochlorothiazide and held her glipizide, fish oil, and aspirin. Her right breast has been marked by Dr. Evans. Her IV D5 normal saline is infusing at 100 milliliters an hour into her left hand. And finally, her IV antibiotics was started 5 minutes ago and is still on infusion. Be aware of any special cultural concerns, including the patient's expressions of pain, family expectations, their ability to verbally express their needs, and any other decision-making considerations. For a geriatric patient, the surgical event may be overwhelming. They may view the hospital as a place to die or stepping stone to a nursing home. This could also come with increased risks with anesthesia and surgery. And keep in mind that they may have sensory deficits or other disabilities hindering their ability to comprehend the situation. A 60-year-old male scheduled for hernia repair at an ambulatory surgical center expresses concern that he'll not have enough care at home and asks if he can stay in the hospital after the surgery. The best response by the nurse is, "Who is available to help you at home after the surgery?" B, "I'm sure you'll be able to manage at home after surgery. It's a simple procedure." For C, "We'll teach you everything you need to know to be able to care for yourself after surgery." Or D, "Your health insurance will pay for inpatient care only if complications develop during the surgery." And that answer is A, "Who's available to help you at home after the surgery?" Because again, this is an ambulatory surgery. The patients are discharged on the day of surgery. The nurse should determine and anticipate what level of care is needed following the procedure. The nurse would also be able to provide instructions to both the patient and the caregiver related to their post-surgical needs. And for our last question in this chapter, preoperative instruction that is appropriate for all patients include A, techniques of deep breathing and coughing, B, descriptions of the planned surgical procedure, C, physical procedures or preparation required before the surgery, and D, withholding all oral fluids or food until after midnight on the day of the surgery. And that answer is C. Physical procedures or preparation may be required before the surgery. Keep in mind that not all patients will deep breathe and cough after surgery, such as a cranial surgery, or need to be MPO. Detailed instructions about the procedure may increase anxiety and are not usually helpful to the patient. Patients should also have instructions on physical procedures or preparation required before the surgery. And this anticipatory guidance goes a long way to decreasing their fear and anxiety. Anyway, that's all we have in this chapter. I'll see you in the next slides.